So specifically with respect to cancer, this is a long list of just some of the things that can be related to depression, specifically from the illness itself, which in the DSM is called depression due to general medical condition. So these are all things that we have to screen for and do some laboratory testing to try to correct before we go ahead and necessarily just prescribe an antidepressant. That's enough about that. Certainly, something that has been talked a lot about in the literature has been the high prevalence specifically of depression in pancreatic cancer, and there can be there's a variety of possible reasons for that. Pain related to pancreatic cancer, though I don't know that it's there are certainly pain syndromes that are related to pancreatic cancer, but it's not more of a painful cancer, I don't know, than other cancers, specifically other metastatic cancers. There may be neuroendocrine changes that specifically are related to depression, and then the general knowledge that pancreatic cancer has a very poor prognosis may predispose to depression.
So the depression in pancreatic cancer isn't preceding the diagnosis? I thought there was something about depression preceding the diagnosis. Sometimes
that's true. Sometimes that can be the first sign, presenting sign with pancreatic cancer. That's right. And that may be related to sort of the idea of paraneoplastic, neuroendocrine problems. We talk about ACTH secreting tumors, parathyroid secreting tumors, but then there's a whole idea of paraneoplastic syndromes that are not able to be tested for. So cytokines being released as part of the cancer illness itself that can contribute to depression. And the cytokines systemically, including in the brain, can contribute to depression. Some chemotherapy agents, specifically those that are more CNS active, have been thought to be able to contribute to mood disturbances. And certainly with radiation, whole brain radiation can cause depression, and steroids can cause a whole slew of psychiatric symptoms. And just another factor is existential concerns that come up that if they're not being worked through or resolved can cause a depression. And some concerns are unfulfilled ambitions, past regrets, a loss of meaning, a loss of dignity, loss of control, and worries about one's family. So now, finally, to the treatment. An important, the first part of treatment for depression is relying on the resources that are already present and relying on social support and family caregivers to help activate resources to buffer against depression. Even helping to structure activities during the day, distraction, things like that, and even primary care providers can play an important role in that regard. Just sort of being open to discussing and sensitive to one's emotional difficulties during illness, if that's perceived by a patient from their primary care clinicians, that can go a long way. Then, of course, there's psychotherapy, different types of psychotherapy, and different types of then somatic treatments. Different types of psychotherapies include cognitive behavioral strategies, which really have to do with, the cognitive part of cognitive behavioral strategies really have to do with sort of identifying, I think some of it comes intuitively, really sort of playing a logic game with patients and listening to some of their attributions and their thoughts, and seeing how their thoughts may be overgeneralized or overly catastrophized, and then trying to sort of get a sense of how much that's just part of their automatic way of thinking, but not their true belief, and trying to address some of those and explore some of those distortions can be helpful. Supportive psychotherapy is generally being more supportive, as opposed to what some people might think about psychotherapy in terms of uncovering and helping patients develop more insight into themselves. That's not that more insight-oriented type of psychotherapy is not going to be typically something you're doing or primarily focused on when you're treating patients, palliative care patients. And then there's a range of psychotherapies that I think are very important to think about in the palliative care setting, because I think a lot of these other strategies, insight-oriented strategies, supportive psychotherapy, cognitive behavioral therapies, don't address. And that's existential psychotherapy, which is helping patients to, the way I see it is helping patients to reestablish a sense of meaning, and redirecting their sense of hope, and that can be helpful. Group therapies are important, and then just general psychoeducation goes a long way. And that's really just providing information, making sure to be providing information about diagnosis and prognosis to whatever extent the patient seems open, and helping them anticipate very concretely what's ahead of them in the near to intermediate future in terms of their treatment. Can help them feel like they have more of a sense of control and mastery, which are important things in treating depression. Then there's sort of more mindfulness-based techniques, relaxation training. Progressive muscle relaxation is something that often goes along with some of the behavioral strategies in treating depression. Biofeedback and sort of hypnosis and guided imagery are all psychotherapies that are helpful in managing depression.